Good morning all. My topic is on non-strabismic binocular vision anomalies in children attending a tertiary eye care center. Why the topic is relevant? It is the second most common optometric condition in the pediatric population. Most of the cases go undiagnosed. It can be largely prevented through the timely identification and appropriate treatment. What is binocular single vision? It is a state of simultaneous vision which was accomplished by the coordinated use of two eyes with the goal that the separate and slightly different images emerging in each eye were appreciated as a single image. Broadly, non-strabismic binocular vision anomalies are categorized into accommodative dysfunction and vergent dysfunction. Accommodative dysfunction include accommodative insufficiency, spasm, infacility, and ill-sustained accommodation, while vergent dysfunction include convergent insufficiency excess, divergent insufficiency excess, basic esophoria, exophoria, and fusional vergent dysfunction. Aims and objectives of the study, it was to find out the prevalence of the accommodative and vergent dysfunction in pediatric population and in various refractive conditions. Materials and method, it was done as a cross-sectional prevalence study at Comtrust Charitable Trust Eye Hospital, Calicut, with a sample size of 366 children between the age of 6 and 12 years. The duration of study was 1 year from May 2023 to May 2024. Inclusion criteria include subjects whose parents are willing to let their children participate in the study, age between 6 and 12 years, best corrected visual acuity of 6/6 in each eye, unremarkable general and ocular health. Exclusion criteria include any significant perinatal history, taking any topical or systemic drugs, history of neurological or muscular disorders, tropias, done any orthoptic exercise in the past, amblyopia, and history of ocular surgeries or trauma. Methodology, after getting consent, detailed patient history was recorded. Basic ophthalmologic evaluation including cycloplegic refraction and appropriate correction was given. Comprehensive binocular vision assessment done including Fourier test for both distance and near, negative and positive fusional vergence using for distance and near with horizontal prism bar, near point of convergence with a Royal Air Force rule, amplitude of accommodation, accommodative facility, negative and positive relative accommodation, vergence facility, accommodative lead and lag using monocular estimation method, dynamic retinoscopy, AC by A ratio using gradient method. The results obtained were compared with the tables of the established expected values by the Sheeman and Big. Coming to result, of total subjects with 366 sample, 42% is having, that is 154 children is having non-strabismic binocular vision anomalies, while 58% was of normal binocular vision. While finding out the prevalence of each of the non-strabismic binocular vision anomalies, convergent insufficiency was the most prevalent, about 20%. Then come the accommodative infacility was about 7.7%, and coming the combination of the convergent insufficiency and accommodative infacility. Age-based analysis of the prevalence of the binocular vision anomalies in 6 to 8, 8 to 10, and 10 to 12 years shows an increasing the binocular vision anomalies. That's increasing convergent insufficiency in the 10 to 12 years. While finding out the prevalence of the binocular vision anomalies in each refractive condition, among the emmetropes, 45% of subjects have convergent insufficiency, while 21 having accommodative infacilities. Among hyperopia, 52.4% is having convergent insufficiency and 14% had accommodative infacility. In myopia, again the most prevalent was again convergent insufficiency followed by the accommodative infacility. In astigmatism group, convergence insufficiency is the most prevalent, followed by the combination of convergence insufficiency and accommodative infacility. While checking the dynamic retinoscopy in myopia, the independent sample t-test results indicate a statistically significant difference between the monocular estimation method of myopic and non-myopic subject. It gives a strong evidence to suggest that values of MEM in myopic subjects of higher side compared to the non-myopic subject, indicating a lag of accommodation in the myopia. Coming to discussion, as per the band study done in Tamil Nadu in 2017, the prevalence of non-strabismic anomalies of the binocular vision found to be 31.5 and 29.6% in rural and urban populations. Convergent insufficiency was the most prevalent. Again, another study in Taiwan with 589 children of age 8 to 13 years found 28.5% presence with non-strabismic vision anomalies, with convergence insufficiency was the most prevalent. Limitation of the study, it was a hospital-based study, so the results must be used with discretion while comparing to the whole population. Equal number of participants in all refractive condition would have given better result for the comparison of the binocular vision anomalies in each refractive condition. Coming to conclusion, non-strabismic binocular vision anomalies are highly prevalent in pediatric population. Convergence insufficiency is the most common non-strabismic anomaly of binocular vision, followed by the accommodative infertility in the population. While considering the refractive condition, again the convergence insufficiency was the most prevalent. Vision screening protocol designed only to screen for the ocular disorders like refractive errors, congenital cataract will miss a significant number of binocular vision anomalies. So, uh, binocular vision anomalies had a significant impact on the academic performance also. So, comprehensive binocular vision assessment and its screening should be a part of normal vision screening protocol. These are my few references.
We are advising screening. Your the variables are too many, no? I think 14. Your table had 14 non-strabismic binocular vision difficulties. What will you advise as the best three or the most important three which need to be tested in all children? Because obviously refractive checking in children is a difficult thing in itself. So you are going to add a battery of tests or battery of workup to that. Then we'll have to be very judicious, no? So of the 14 or 15 which you listed, which will you say are the most key three tests which we need to add to every child who is being tested? And you'll also have to tell what are the symptoms in those child which will make the practitioner think that there can be this kind of an issue and try to test it further. So those kind of interventional aspects should be added to a study. Only then the study will have more acceptance, more. You are just making it look like an analysis of the issue. Issue analysis is good in a way only when it gives positive ideas on intervention. Okay.
You're told about convergence insufficiency, some of the patients, most of the patients. They have not, they didn't show any type of squint also at any point of time during the daytime or something. Because their insufficiency, naturally they can have sometimes, going, the eyes may go out. Because you're told non-strabismic. Here, some of the convergence insufficient patient might have gone for sometimes at least intermittent type of deviations. Huh?
Including only the tropias, sir. We are including the phorias.
You have not included 4 years.
Including the phorias, excluding only tropias.
Oh.
Constant.
Okay, okay, nice. I can't follow.